cycle can live for decades. They can live for quite a long time. So NETs are epithelial neoplasms. They can originate in almost any primary site, most commonly in the GI tract and the lungs. Most grow slowly in comparison to their adenocarcinoma counterparts. Somatostatin receptor expression is very common. It's really the rule as opposed to the exception. And the majority are sporadic, and a minority, less than 10%, are associated with inherited syndromes. In terms of the molecular makeup, chromosome alterations are common and somatic mutations are rarely actionable. In terms of the WHO classification for lung neuroendocrine neoplasms, again, I'm going to focus mostly on the well-differentiated NETs. So there's apparently a good story that the physician that came up with the GI and lung neuroendocrine WHO criteria worked on the same hallway at Memorial, 2 different physicians, and they decided they wanted completely different nomenclature in terms of how they labeled these, which is why we have the typical and atypical for lung, which is unusual. And then we have the grade 1, 2, 3 for GI. So I don't know if that's urban myth or if that's true, but so we are moving towards a consolidated nomenclature. So we're trying to use grade 1 now more for typical, grade 2 for atypical. They are typically defined by mitoses and presence or absence of necrosis. Ki-67, it's making its way into the nomenclature, and I'm typically asking the pathologist to get Ki-67 on all of the biopsies. Both Ki and mitoses kind of are a marker of proliferation. I find them both helpful. So back to a little bit around the molecular characteristics of lung neuroendocrine neoplasms. So the MEN1 gene mutations are actually very common in typical and atypical, up to 11 to 20%. Chromatin remodeling gene mutations are common, and then mutations in the PI3 kinase and AKT-mTOR pathway are also common. These are actually very common mutations in the GI and neuroendocrine tumors as well. And so again, focusing kind of on the red box for typical and atypical. So in terms of the diagnostic workup, cross-sectional imaging is still the primary modality that we prefer for monitoring patients over time. A multiphasic CT is often helpful as these are very vascular tumors. For liver imaging, we will use an MRI occasionally, but a multiphasic CT is perfectly acceptable. We now have replaced Octreoscan with gallium-68 PET or copper-64 PET. Octreoscan has gone by the wayside. Actually, a really nice example of that, and I don't think you can, oh, you can see my pointer here. So this is an Octreoscan, again, not really used anymore, and the same patient with a gallium-68 dotatate PET. So really you can see that the resolution is far superior, and it's just a much better imaging tool. So the general rule of thumb is that for low-grade neuroendocrine tumors, they are positive on the somatostatin receptor imaging and negative on FDG PET, and the opposite is true for high grade. So we would see positive in FDG PET for high grade tumors and negative on the gallium-68. For lung NETs, often we'll use bronchoscopy, brain MRI, generally only for small cell, but if you're worried and have someone with a very clinically aggressive atypical NET, I might consider getting brain imaging just at baseline. We talked a little bit about the tissue diagnosis already. And then a characteristic of neuroendocrine neoplasms is that many of them will secrete hormones. That's why they have their name, endocrine. So lung NETs can secrete serotonin as measured in the urine as a 24-hour collection of 5-HIA. One thing that's really helpful is we now can check 5-HIA in the plasma as opposed to having patients collect a full 24-hour sample. That's available as a Yale send out, but you can order that. And some lung NETs can secrete ACTH and other funny hormones. And then a key takeaway is resist the temptation to order chromogranin A. So that is not a secretory hormone. It is a really imperfect tumor marker. And I find that patients get more anxious following that than it is helpful for anybody. So these are key characteristics that I think help me help guide my selection of treatment. So functional status, we'll touch on I'll go over a few of these in some slides. Primary site, So lung versus GI, some of our FDA approvals are actually dependent on primary site, stage, volume of disease, degree of differentiation, grade, somatostatin receptor status, germline and somatic mutations, sex, gender, and race. A lot of female patients may have greater side effects than male patients, and that's a project that's ongoing with my team. And then thinking of social determinants of health. So the classic example of a functional NET is carcinoid syndrome. So as mentioned earlier, this is the secretion of serotonin. Serotonin measured in the plasma is actually, it fluctuates quite a bit. So it's much better to check that as a 5-HIA, again, urine or blood. And it happens in about 10% of patients with small intestine NETs and even smaller percent of patients with lung neuroendocrine tumors. And it's defined as the production of peptides and amines that are associated with symptoms of hormone excess. So those symptoms may be flushing, diarrhea, bronchospasm, cardiac valve fibrosis, primarily right-sided valves. So you can see in the picture here on the left is venous telangiectasia. Typically happens nose, cheeks, and upper chest. Patients are often misdiagnosed with rosacea or told for years that they have a dermatologic condition. And a picture of pulmonary and tricuspid valve fibrosis here as well. The large majority of patients will have non-functional disease. So that is really defined as no measurable hormone that can be attributable to symptoms, or the symptoms are not really from hormone excess. And I'm a believer that there are probably some hormones that we don't know about or don't know how to measure. There are some patients that can be quite complicated where they may have symptoms that you think, gosh, this sounds like it should be something that I can measure, and we just never find something. So that does happen. So the LungNet treatment approach is really like an evaluation with almost any solid tumor. So if it's a local, regional, or resectable, we try to remove it. So ideally sparing lung parenchyma, but lobectomy or other anatomic resection, mediastinal node dissection or sampling. Occasionally, if patients are either not surgical candidates, we might consider ablation or SBRT. For local, regional, or unresectable disease, one of the nuances with neuroendocrine tumors is that we sometimes will consider surgery for patients that it may be different than the criteria than you think about for adenocarcinomas, just because the disease is more indolent and it may help reset the clock. For patients with metastatic disease, however, we will talk a little bit about some systemic treatments. And then DIPNEC I'll leave for the end. So like that timeline, we actually have a lot of treatments available for the metastatic disease. They include everolimus, somatostatin analogs. We have a soon-to-be FDA-approved treatment in cabozantinib, chemotherapy, and I'm going to talk a little bit about a newer treatment called radioligand therapy. But one of the challenges is that we don't have an optimal sequence in which we know to treat patients. So I'll start just by talking about treatments for hormone control. So the standard are using somatostatin analogs. So someone with carcinoid syndrome, we would start them immediately on lanreotide or octreotide. Those are both long-acting. We sometimes will use short-acting octreotide to bridge them. And there are one exciting area of research is oral somatostatin analogs. These are in clinical trials right now, and so hopefully we'll be able to bring those to patients. One of the newest treatments is actually an inhibitor of tryptophan hydroxylase. So that is the rate-limiting enzymatic step from conversion of tryptophan to serotonin. So this is for patients with carcinoid syndrome diarrhea. And this was FDA approved a few years ago, and it's a pill that blocks that synthesis. So it's given in combination with a somatostatin analog. So treating systemic disease or metastatic disease has a number of different buckets. So we'll use somatostatin analogs to slow down growth. It won't shrink the cancer. We'll use targeted therapies like everolimus or cabozantinib, also generally yields stability. If you have a patient that's in need of tumor shrinkage, you might consider chemotherapy. Immunotherapy has played some role in low-grade lung NETs, but certainly not the way that it has in adenocarcinomas that you guys have seen. And then radioligand therapy is a peptide linked with a radioisotope that is really a new class of therapies for solid tumors. We have an FDA approval in GI neuroendocrine tumors, and there's an FDA approval in prostate cancer. So expect to see this more in other solid tumors. So I'm going to go through just some key studies looking at some of these treatments before we get to talking about some of the cases. So somatostatin analogs can be given both in short-acting and long-acting form. For tumor control, we go directly to using a long-acting agent. So that's either octreotide at 30 milligrams monthly or lanreotide. And we don't generally need to overlap with a short-acting unless a patient has carcinoid syndrome. And it's very well tolerated. Some of the common side effects include hyperglycemia, cholelithiasis. Patients can have a little bit of GI upset with their first couple doses. So these were studied in clinical trials to demonstrate anti-tumor effect. The main trial is called the Clarinet study. And in that study, you see the figure on the right, that demonstrated a benefit in progression-free survival for patients who got lanreotide. One interesting, if you're used to kind of another, and I guess lung adenocarcinoma looking at survival curves, the preferred primary endpoint for NETs is progression-free survival, just because OS would be a really impractical endpoint given that patients live for much longer. So just expect that our preferred endpoint is PFS. And as mentioned before, so we see PFS benefit, but we generally do not see shrinkage. So the response rates are single digits. And so lanreotide was FDA approved for tumor control in 2014. This was for really GI neuroendocrine tumors. We can extrapolate, and actually there was a clinical trial that specifically looked at lung NETs. So the SPINET clinical trial looked at lanreotide versus placebo in low-grade lung neuroendocrine tumors. It unfortunately closed early due to poor accrual. However, in the, again, small study, given the numbers, there was not a statistical difference between lanreotide versus placebo in the overall study population. But when we look at typical versus atypical, the feeling is that the patients with typical carcinoids benefited more. We still use this in practice, again, just because this is such a well-tolerated drug and some patients can have benefit. We just don't have high-level evidence to use it. So this field of using the radiopeptides, so I'm going to move on to thinking about that, is an emerging field called theranostics. So it essentially means a combination of a molecularly targeted therapy and a diagnostic imaging tool that uses the exact same target. So think of it as the somatostatin receptor. So in my cartoon here, I'm hoping to take a population of patients, figure out who has that receptor. I have a PET that will help me identify those patients. And then I have a targeted therapy that targets that exact same target. And so if you think of it as sort of a lock and key, this is an analogy I'll use to describe this to patients. So the target is the lock, that's the somatostatin receptor. The ligand is the key, that's a somatostatin analog. So actually we're using this approach already when we use octreotide or lanreotide. It goes directly to that receptor. But in this case, we're attaching that peptide to a radioisotope. You can use an imaging radioisotope like gallium-68 or copper-64, or you can use a therapy radioisotope like lutetium-177. And so then we think of these having these theranostic pairs. You have an imaging tool and you have a treatment tool. And these are just some examples. I put the prostate one here. So both of these agents, so lutetium-177 dotatate is FDA approved for GI and pancreas neuroendocrine tumors, and lutetium-177 PSMA is approved for prostate. So the trial that led to approval in the GI neuroendocrine tumor world was called the NETTER-1 study. You can see a big separation of the curve, so a huge benefit in terms of progression-free survival, where the hazard ratio was 0.21. And overall survival, again, it was allowed crossover and was didn't officially meet an OS endpoint, but I would argue a clinically meaningful benefit of about a year in terms of the difference between the two arms. Very well tolerated, can cause some mild myelosuppression. And I should mention, it's just 4 total doses. They're separated by 2 months each, so it's a finite amount of treatment, which is, I think, great for patients. A subsequent study called the NETTER-2 study looked at this in slightly higher Ki-67 patients. So a Ki-67 patients with a higher Ki-67 of 10 to 55%, and in the first line setting. So that first trial I mentioned was in the second line setting. This also showed a progression-free survival benefit. And so we now have this agent we can select and decide, do we want to use it after progression on octreotide or lanreotide, or do we want to use it in the first line setting? And I think, again, it's all about patient selection. Who are you most worried about? This agent has about a 20% shrinkage rate, so it does yield objective shrinkage if we need that for patients. Just want to mention this has been a really interesting partnership with radiation safety. So we have to really think about this for patients. This is an example of what we hand out to our patients and tell them they have to avoid extended time in public spaces. And this is mostly just for 3 days. We recommend that they use a private bathroom for 3 days. They can't sleep with a partner for 3 days. So the beta particle that this, and it made me realize that physics and chemistry actually do matter for medical school, because I had to go back and relearn all this stuff. But a beta particle, that is what lutetium-177 emits, only travels millimeters. So in reality, it's very safe. It poses very little risk to the general public. But as it's excreted in the urine for the first 3 days, if you get in contact with the urine, that's when it can pose some exposure risk. There is an open clinical trial with lutetium-177 dotatate in lung nets. It is lutetium dotatate versus everolimus. So everolimus is an mTOR inhibitor, the only FDA-approved treatment really for low-grade lung nets that are metastatic. So this is a 1-to-1 randomization. It's through the National Clinical Trial Network and is actively accruing. This is just as a kind of a highlight where we are trying to develop new radioligand therapies. So I mentioned lutetium-177 dotatate emits a beta particle. Lead-212 emits an alpha particle that travels micrometers and has a higher linear energy. So in theory, it's more effective and less toxic. This is just a picture from a phase 1 study of a patient with a metastatic bronchial carcinoid. And you can see the figure 1 on the left and figure 2 was a different patient, but both of them had a really remarkable response over time. So you can see after 2 injections and after 3 injections and then after follow-up really made most of those avid spots go away. So we actually have a clinical trial here of a different alpha therapy with actinium-225 for patients with GI and neuroendocrine tumors, but I suspect this will make its way into trials for lung nets as well. So I mentioned there are a few other targeted therapies approved. So this is one of the few therapies formally approved for lung nets. This was done in a series of studies, and actually everolimus is FDA approved for lung, pancreas, and GI neuroendocrine tumors and was approved in 2011. Again, on the basis of an improvement in progression-free survival. You can see about an 8-month difference in PFS of everolimus versus placebo. 2% response rate, so again, generally does not shrink the cancer. This is a harder drug for patients, so it can cause pretty significant fatigue, stomatitis, can cause rash, diarrhea. One thing I didn't mention here that Jennifer and I have shared, patients can cause pneumonitis, and so some of these patients will have to send to you all to help manage that. That's probably a 10 to 20% risk of pneumonitis. This is one of our newest, it's not yet FDA approved, but patients with lung nets were included in this clinical trial. So cabozantinib is an oral tyrosine kinase inhibitor. This trial just reported out about 6 months ago. And so the non-pancreatic nets included lung. And so this extra pancreatic net cohort showed a benefit, again, a prolongation of PFS for cabozantinib versus placebo. The response rate was also single digits, so only about 5%. And so again, hope to have this as another tool for patients. It's another difficult drug in terms of side effects. I find that both everolimus and cabozantinib can be really difficult in terms of fatigue and quality of life. We will sometimes use chemotherapy. So capecitabine temozolomide, I think, can work quite well in lung nets. We don't have large prospective trials. We have some smaller retrospective ones. This was an example of a retrospective study just of 20 patients. But for patients who need objective responses, I will try using this medication. Often I'll use temozolomide alone for older patients, so I'll use the combination, and again, very well tolerated and can yield shrinkage if that's something that we need. I thought I would just throw in one slide on immunotherapy. So we wish we could jump on the immunotherapy bandwagon for low-grade NETs. It really hasn't proven helpful in either GI low-grade NETs or in lung. This is a very small study that included a few lung neuroendocrine tumors. This was of ipilimumab and nivolumab, again, used commonly in other cancer types. So some signal, but typically we're reserving the use of immunotherapy for much higher grade tumors. And I think we just have to figure out how to turn some of these cold tumors into immune responsive tumors. And so far, I generally am not using this for low-grade lung NETs. All right, moving on to talk a little bit about DIPNEC. So DIPNEC is sort of a homeless entity. It's sort of, I'm trying to drum up some interest in this in part, I think, here today. So diffuse idiopathic pulmonary neuroendocrine cell hyperplasia was in fact first described many years ago in the early 1990s by this brief report in the New England Journal of Medicine. And DIPNEC is associated with both invasive tumorlets and formal neuroendocrine tumors. And you can really see the full spectrum. So on a high power photomicrograph, you can see a normal bronchiole, and there are a few neuroendocrine cells demonstrated by the arrows. On a higher power view, we can see an abnormal bronchiole that shows nodular hyperplasia. That's shown by the asterisk, and then subsequent lumen obstruction. So this isn't even formally a neuroendocrine tumor. This is just hyperplasia. And then a low power view of another bronchiole that shows, sort of show here, the arrowhead shows linear and then nodular neuroendocrine cell proliferation, and then a formal tumorlet. And so I think of DIPNEC like you would think of a polyp in the colon. It is sort of Jennifer and Katie and I were just talking, it's really hard to describe this to patients. It's not, DIPNEC itself is not yet a cancer, but it can progress that way. And so it's a precursor lesion. It does require monitoring and can certainly cause symptoms. So a DIPNEC diagnosis in the newest 2021 WHO classification has both pathologic criteria and clinical criteria. So the essential criteria to make a pathologic diagnosis is neuroendocrine cell hyperplasia and or tumorlets, and both are usually multifocal. For desirable criteria, carcinoid tumors, single or multiple, constrictive bronchiolitis, and multi-D exclusion of reactive NECH and tumorlets. The clinical criteria, essential ones, are symptoms related to airway obstruction, often misdiagnosed as asthma, CT findings of mosaic attenuation, and plus minus bilateral nodules, often less than 5 millimeters, but some can be greater. And then desirable criteria, middle-aged women with dyspnea, and path confirmation of multifocal NECH plus or minus tumorlets. So this is based on some really nice review articles and some clinical practice, and I would welcome crowdsourcing on how we think about working these patients up. So I think with a patient with a suspected DIPNEC, respiratory symptoms, non-diagnostic radiographic abnormalities, thinking about bronchoscopy with lavage plus or minus biopsy, and then a surgical biopsy if we can't actually make a diagnosis. Confirmed DIPNEC, I think we are trying to see these patients in medical oncology. I think that that's helpful in terms of monitoring. Jennifer and Katie have kindly agreed to, we've started sort of a mini clinic where I'm sending them really all of the patients I see with DIPNEC. And I think that patients who carry this diagnosis have often been passed around in the medical system for years, misdiagnosed as having asthma, told that what they have isn't real. Many of them carry, I would say, significant mental health challenges because of this and have mistrust of the medical system. So I think really an opportunity for all of us to learn more. So treatments for DIPNEC that are reported in the literature, again, based on like very low level evidence, conservative management, lung resection, if there are dominant nodules, I would say probably scant data on lung transplant, formal chemotherapy, mTOR inhibitors like everolimus, systemic steroids, inhaled steroids, somatostatin analogs. I will say the one thing I will often, and certainly in partnership with Pulmonary, let you guys do sort of official workup, PFTs, thinking about steroids and inhaled bronchodilators or inhaled steroids. If patients are refractory to those initial therapies, I will sometimes try somatostatin analogs. They, again, are fairly low risk, can sometimes lead to some symptomatic improvement, but it's a tricky, frustrating diagnosis to treat, I think, until we really understand more. So I have a few cases here. These are like cases that are actually happening live in real time. So this is a 75-year-old woman who presented with left leg pain and was found to have a large femur mass. You can see that on her FDG PET here. She had not had additional workup. They went straight to do a biopsy of this left femur lesion, and it demonstrated a well-differentiated net, Ki-67, 6 to 10%. TTF1 was variable. A CT cap showed a 1.5 centimeter left upper lobe mass and liver lesions. And then what I've put here are both, I started with a gallium-68 DOTA PET. It was essentially negative or photopenic, where she had these metastatic sites, yet the FDG PET was actually more avid. What's interesting, I think, with both typical and atypical lung net compared to GI neuroendocrine tumors, we see, I would say, 70 to 80% positivity on gallium-68 DOTA PET, but not all. And certainly for patients with higher Ki-67, we may just not see avidity on the DOTA PET. So I will sometimes get both. It teaches us a lot about biology. Certainly, the more avid it is on FDG PET, it makes me worried about a more aggressive biology. So metastatic, probably typical lung net, metastatic to bone, liver. What's the best first treatment? Active surveillance, steroids, somatostatin analog, everolimus, capecitabine, temozolomide, and you can pretend that you're an oncologist. Any thoughts? So I'll help answer for you. So this is a patient, she had a negative DOTA PET, so really didn't have evidence of somatostatin receptor avidity. You really need that to think about using even octreotide and lanreotide, even though those are very well tolerated. Probably wouldn't put her at risk, but likely wouldn't work. So everolimus is the main FDA-approved agent that we have. Sadly, I just saw her last week. She has progressed immediately after just 3 months of everolimus. So we will probably be thinking about using capecitabine temozolomide for her. We just presented her case in tumor board. Unfortunately, she's had new lung nodules, lymphangitic spread, progression of her liver lesions. So it is, I wish we had better predictors for who does and doesn't respond and who is going to have a more aggressive course, but I'm worried about her. The fact that she presented with like a 6 centimeter femur mass to begin with was also probably not a great sign. Any questions or comments on that case? Yeah.
Just curious, did you get tissue from the lung nodule, or was it just presumed metastatic?
I think it was presumed. Yeah, sure. The question was, did I get tissue on the lung nodule? I don't think so. That's a good, I will have to get back to you on that, but yeah, presumed to be metastatic. Anything else? Okay. So case 2 is one that I share, I think it's with Katie, a 36-year-old woman with a history of heavy smoking, chronic cough, and a 1.4 centimeter left lower lobe nodule and a 5 millimeter left upper lobe nodule. Her lung nodules, I think she was being followed given her smoking history, were followed for a couple of years and then started growing. So she had an FNA of the left lower lobe nodule that showed typical lung net, Ki-67, 5%, no necrosis, and TTF1 was positive. Neither the FDG PET or gallium PET were very avid. We just presented her in thoracic tumor board, and Christina Fuss was very kind and she's like, this is the best teaching case. So I was like, all right. So it shows really classic mosaic attenuation. So that is pathognomonic for dip neck. And it shows this sort of patchy, kind of heterogeneous pattern of lung density is appearing as patchwork areas that you can see. And then this lung nodule shows very kind of mild avidity in the upper right box. So this patient was felt to have both dip neck. She had like multiple small bilateral pulmonary nodules and also formal like neuroendocrine tumor. So we decided, even though she had 2 dominant lung nodules, they were pretty small, 1.5 centimeters each. Well, maybe I should, here, I'm gonna ask you what we should do. So what's the next best step? I gave you the same options as before. So dip neck with bilateral true net, only one of which had been biopsied, active surveillance, steroids, somatostatin analog, everolimus, Cape-Tem. Anyone want to throw out a guess? Her imaging was negative. Both DOTA PET and FDG PET were negative. She is symptomatic. She has cough.
What was the original? She had original PET itself, right?
No, her nodules had just been followed. They were biopsied only after they started growing. And they showed like the FNA was net, like typical net. And then she has imaging findings consistent with dip neck.
That's a question.
Yeah.
I think your case questioning was because right now, the most, if I understand the case correctly, you have several nodules. It's too much. So she has several, or but on a background of a diagnosis of COPD based on a smoking history.
So
And because,
yeah,
all right, so is there a smoking history?
there is a smoking history.
Or asthma history? And at this point, we see air trapping or mosaic attenuation in many, many patients. And so I wouldn't necessarily say that we actually know that there's diffuse neuroendocrine disease driving her airway obstruction or mosaic attenuation at this point. And so it might not change the treatment, but, and they may be linked, like you might treat the neuroendocrine net anyway,
Right.
and then see what happens. But, how hard do you have to push to actually get tissue to show that you actually have dip neck? Because presumably the disease that we're talking about here, and we probably have a lot of these patients in the asthma clinic that we haven't diagnosed, is that you need broncholytic evidence of neuroendocrine disease.
Yeah, so it's an excellent question. We did talk about that briefly in tumor board. I think the feeling was that they didn't want to do additional surgical biopsy to get more tissue. She had been proven by FNA to have neuroendocrine tumor in the nodule. And I think because she had scattered small bilateral nodules with the mosaic attenuation, it was presumed that this was all dip neck. But yeah, an excellent question.
But she did have nodules on the CT.
Yeah. Yeah.
So we didn't see.
Yeah, I didn't show you.
This would have stressed us out a lot and actually add another 15 years to that, to her age.
Yeah. 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 I think, yeah. And again, to your other question, I mean, she'd been told she'd had asthma for years. So again, it's a lot of, I just met her in the last few months. I don't know, Katie, I think Katie, you saw her. I don't know if you remember if you remember additional history, but I think she'd been told she'd had asthma for years.
Yeah, I'm just pulling up her chart now.
Yeah. Yeah. Anyway, we can talk more afterwards.
The problem is asthma is a clinical diagnosis, so we can't really
Yeah.
figure out what it is. How do you know it's not?
Well, I would say you actually need airway tissue to know
Yeah,
and to understand, because you might treat this patient's asthma with a biologic.
yeah.
My comment was I wonder if cryobiopsy could help in that setting if the surgeons are reluctant to go with the full.
Oh, that's a good, all right, I'll send her to you guys. So we chose active surveillance, at least for now. So we're gonna monitor her with a CT. She's being followed in pulmonary. But I think this was another example of a patient who had kind of been in the medical system for a long time and is feeling pretty frustrated with how she's feeling. But I'd welcome other, Katie's madly reading about, I should have given you a heads up about this.
Yeah. I mean, I think we often, there's a couple different pieces to it. One is if they haven't had tissue yet of the nodule, it often drives how we go for tissue
Right.
for the nodule in hopes that as bystander, you pick up some of this other pathology. But from like a transbronch, you're not going to, right? But I think the other situation we've ended up in trying to extrapolate what we think is the driver is therapeutic trials of intervention with reassessment of symptoms. And the behavior of the nodules doesn't always move in tandem with the behavior of the symptoms from dyspneic, if it is indeed dyspneic. And so you could end up with really discordant responses.
How do steroids, what do steroids do for this? Because if you're worried about asthma slash COPD, you could actually give her a course of steroids and see if she gets better, right? And does it shrink the dyspneic?
It won't shrink. I put it up there just as a, I don't know, to throw you off. Yeah, yeah. So I think it's not used as a treatment for dyspneic.
So I have a crazy dyspneic lady who's also got reflux and who had non-caseating granulomas in a lymph node, and we thought she had sarcoid for years until they took out her lobe and she had a neuroendocrine
Oh,
tumor, and she's
interesting.
on steroids. So I always wondered, did the steroids control her dyspneic?
I mean, I will say that like the inhaled steroid combination with beta agonist helps, but you could imagine any number of reasons why that helps, because if you have this pathology in the airway, having bystander inflammation isn't unreasonable, right? And so even if you can gain a little ground in terms of their symptoms, mainly suppressing cough, which is often a big rate limiting factor, but they'll sometimes going on ICS-LABA, they'll report that they have improvement in exercise tolerance too. So there's something else there, you know, that you're intervening on with the inhaled therapy. It's just, there's also a good chunk of them that don't get any relief from that at all, but do with other therapy, systemic therapy.
Again, classic case in our which is micronodular disease with the evidence of fixed obstruction.
Turn it on.
Clearly impaired today. The classic case is micronodular disease with fixed obstruction without a lot of reversibility, and cough is a predominant symptom. But there isn't really a lot of literature of it in or large case series. So, but we get
For help, that's a
we get a
great
lot of
trainee-
scans like, you know, where it's a consideration because there's mosaic attenuation and multiple nodules. And so, you know, and then in many, many cases like that, we just follow them because they're nodules that are, you know, less than 5 millimeters. There's no smoking history. They look like what we would call a T2 low asthmatic, you know, and, you know, you treat them like an asthmatic with inhaled steroids, or, you know, you approach them symptomatically. But is there a way, you know, that we could less invasively increase our likelihood? Like, you know, you mentioned that chromogranin is obviously not a specific test and very, you know, not useful, but, or if we did transbronchs, is there immunohistochemical stain we want to make sure that we get? You know, you had IH on there. I don't know what you're staining for.
So chromogranin and synaptophysin and then TTF1.
Yeah. So, I mean, is there something that, or should we be getting, octreotide scans on all these patients? I don't think it's sensitive enough to pick up
Yeah.
micronodular disease like that. But, what do you suggest?
Yeah. All good questions. I don't know that we have answers to all of them. I am still getting the DOTA PET scans. Sometimes we'll look at it. So I am starting to get those. I think just it's non-invasive and it's a tool and it may pick up on larger nodules. We don't have great blood-based diagnostics. So I probably would not use chromogranin. I think that the immunohistochemical in IHC stains may be helpful. And if we can do transbronchial, like maybe that's helpful. This is great brainstorming because I think I was just sharing earlier that I have a lot of these patients in my clinic now. And so I think it's a real opportunity for us to collect our own experience and actually think about scientific questions that we can ask in this population. So I don't know if Katie or Jennifer.
Now that I have the microphone, I'll just add to that, and it's working. I'll just say, I think, I'll turn it, somebody you're going to have to wrestle it away from me, Naftali. I think that it would be interesting to do bronchial biopsies, small airway, because if this is presumably a diffuse disease, then it's possible you'll see an increase in the number of neuroendocrine positive cells, much like we see, like in making a diagnosis of myeloma, where you had a certain percentage of cells increase. So, because I don't think we normally do any neuroendocrine staining on transbronch. So we all believe we should be probably bronching more people with airway obstruction in general, but in this kind of situation, maybe that would be useful to know.
Well, we have an opportunity to create our own algorithm, I think. So like if we want to do something that's in the spirit of trying to learn more and actually could study it, I'm all for doing that. So
We should come up with a protocol.
Yeah.
We should come up with a protocol for anyone who were thinking about this on what to do, so we can just open it up and do, so we don't have to try to remember what we said here. Right? Let's spread it around. Let's do it.
Yeah. So that, yeah.
Quick question. Let's say this is now. All right. This is a very interesting biology. So this is SSA negative and FDG negative. If it starts growing, this particular case, yes. If this starts growing, the question is, would that be the time that you will start thinking about TKI? Or no, you're going to go straight to chemo? When it's not growing, everything is fine. Maybe you give a course of steroids, some inhaled steroids, things are better. But when it starts growing, would you go to TKI first or straight to chemo?
So that's a great question. I think what we don't know, so if DIPNEC does not express somatostatin receptors, as it evolves into true NET, what we don't know is does it acquire somatostatin receptor expression?
Okay.
So maybe. And I think so my approach in that first patient was to go to a targeted therapy first before chemo. So she got everolimus and now is progressing, and now I'm going to put her on chemotherapy.
That's exactly my question. So everolimus, because first of all, you talked about the rate of mutations of those, and that was not very high.
That's correct.
So in general, just the pathway downstream you're going after.
Yeah, and I think in part, everolimus is not super easy, but at dosed appropriately, it's probably a little bit easier than chemotherapy. So for patients, one of my mantras is I don't want the fix to be worse than the problem itself. So for a patient that's not super symptomatic, so I started her on everolimus, but I'm even more worried now given the pace of growth in biology. So she gets chemo. We actually, in fact, talked about platinum etoposide versus CAPE10, and she may ultimately get platinum etopa if her disease progresses more.
I think we're going to turn things back over to
Okay.
Pam so that
Okay.
she can finish
Okay,
up
no,
with
I
you about
just,
5
yeah.
minutes.
I think I have one more slide. So anyway, this patient we're monitoring, but maybe I need to send her back to get a biopsy. So, okay. So this is just the last slide. So hopefully, and it sounds like we've not done a NET talk in pulmonary grand rounds for a bit. So hopefully I've taught you guys a little bit that although rare, there's been really just an explosion of research in this space. They're really deserving of high quality, basic translational clinical research efforts. We have many treatment options. However, for lung nets, level 1 data are limited. Hopefully we can at Yale contribute to more of that. Tailoring treatment for patients, we just don't have data to support an exact sequence of therapies. So actually these types of discussions are great. Requires a really careful balance of patient and treatment characteristics as we think about what therapies to use. And really a key takeaway, and I actually really value all the input, is that multi-D care for these patients is really critical. So I join Thoracic Tumor Board when I can, partnering with members of your group. So thank you so much for the opportunity to talk today. Happy to take other questions too.
Here? No, Sherman? Okay. All right.
The case is clearly like
Any
touched, yeah.
Are there from the chat?
So steroids don't worsen it.
We don't believe so.
There is this talk about steroids worsening it. This one,
We don't believe so, but yeah, good question.
Is radiotherapy something you can return to and ever after initial course of therapy, or
External beam, or you're taking
No,
the radioligand therapy?
the
Yeah,
radioligand?
so that's a great question. So there are actually some clinical trials looking at retreatment. So the question was around, can we use radioligand therapies again? So a standard initial course, and I have treated a few patients with lung nets who have avidity, is 4 doses. We then monitor them off therapy every 3 to 6 months with scans. And on average, from that NETTER-1 clinical trial, median progression-free survival was about 2.5 years, which is great. If they progress again, the question is, can you retreat them? And I think outside of a trial, we're using 2 additional cycles of Lutathera. There are actually a couple of clinical trials looking at retreatment. There's one in the US and there's one in Europe. The clinical trial that I mentioned with the alpha therapy is actually a retreatment trial. So it's for patients who've progressed after 4 cycles of Lutathera, and then they get 4 cycles of the alpha therapy. So a risk I didn't highlight here, there's about a 2 to 3% risk of myelodysplastic syndrome after these radioligand therapies. And the thought is that if patients also get alkylating agents like temozolomide or get a second round of radioligand therapy, that they may be increased risk. And it's real. I've certainly seen it, and it can derail all attempts at other future therapies. So we have to think about that.
Oh, Dr. Mathay has a question. I have to be able to read it. Is Yale a major referral center for NET under your direction?
Yes, it is. Yeah. So I only see neuroendocrine tumors, so which has been really fun. I see a few of my team members are in the back. I asked them to come. So we see patients with NETs of all primary sites. I was sharing with some folks earlier that the large majority are GI neuroendocrine tumors, but I will see, I think I have patients with GYN neuroendocrine carcinomas, head and neck, lung. So we're certainly growing. These are patients, again, because they tend to be more indolent cancers. They seek expert care. So they will go around to centers where there's expertise. Patients will travel for this. So this can be sort of a destination center. So we could create a destination DIPNEC center.
Destination. Thank you. Thank you so much for coming. And I appreciate you coming here also to celebrate Women's History Month. We are so excited to have you here, and we're glad to be. Thank you, everybody, for coming today. I know there are a lot of things going on in the world, both to us and nationally. So Dr. Kunz has been involved in the executive committee at at SWIM, which is Committee of Status of Women in Medicine. And she's going to be taking on leadership with Dr. Teddy in a few months, correct? In the summer. Lauren, Dr. Tobias and Lauren Tobias, there's so many Laurens. Lauren and I are both your SWIM liaisons, so we're trying to keep a temperature on things and have been bringing information about going on even just this weekend, giving her some updates about what's been happening in the section and bringing it to the executive committee and to SWIM as to sort of represent us, just in many ways FAC does as well, to the dean and other parts of the university, and kind of collaborating with affinity groups. SWIM's actually been around since 1979 and have been really involved in some things that we may take for granted now, including issues around compensation for those who've been here long enough, sort of issues around sexual harassment, and so have been active and also listening to some of our concerns on the clinical side, certainly about Access 365. So, as I was thinking about it, it just so happens that everything that's going on in the world and is personally affecting us, both fellows, faculty, and all different faculty tracks. It just so happened that you were actually coming. And I was trying to think of something. These are certainly challenging.
So then I got
times.
asked to give a second talk. But
Yeah. I said, you're going to make us all feel better. But I don't know that we all have a lot of answers, and I certainly appreciate Dr. Kaminsky and Dr. Steiner for supporting this event. Dr. Shinui and Dr. Redlick have also been very active in SWIM over the years, by the way. But all we can at least do is kind of come together and vent partly, but also maybe come up with ideas and try to keep the lines of communication open, both amongst ourselves, because we're all so busy now, but with others who might have some channels to other affinity groups and to leadership beyond. So we can kind of keep plugging away during this time. So thank you for making the time to actually come today and come to the reception. If you're able to, even just for a few minutes, I tried to bring, we try to have some toys out there on the tables for you. But I want to turn this over to Dr. Kunz to kind of talk a little bit more about SWIM initiatives.
I promise this is not another 45-minute talk, so brief. So thanks again. This is actually a shifting gears entirely from my sort of science clinical lens to thinking about advocacy and thinking about how we really can all work together. So I'll give a little brief history on SWIM. So as Maridu said, SWIM has been around for a long time. Its mission is to promote equity for women faculty at the School of Medicine in promotion, salary, retention, leadership opportunities, mentorship, benefits, and recognition. This is really directly from the mission statement. And then in order to achieve the above goals, the hope is that we develop and help implement structural changes and collaborative outreach to others to support an inclusive, diverse, and welcoming environment. So really intended to be everybody working together. So established 1979. The SWIM Executive Committee is a group of 20 individuals. I highlighted Carrie Redlick's role in this from your section, really spanning faculty rank, sections, generations. I mean, it's really a wonderful group. I joined SWIM. Some of you may know I've been at Yale for about 5 years. I was at Stanford University previously. I joined in July of 2020 during crazy early COVID time, and actually finding SWIM and joining SWIM as a liaison initially helped me find community at a time that we were all remote. And it was a really wonderful way to meet people. So your two SWIM liaisons, as mentioned earlier, Maridu and Lauren. So the SWIM liaisons are another part of SWIM. They represent really all of the different sections and have multiple liaisons per section and per department. And it's really across the School of Medicine. And the SWIM liaison meeting topics include OAPD, so Bob Rohrbar has come and spoke, appointments and promotions, Sam Ball speaks regularly, the Title IX office has spoken to the liaisons. We are hoping to have a new announcement soon on the Associate Dean for Gender Equity, who also meets with the liaisons. Access 365, the Dobbs decision, there are retreats. So it's actually really, if you have questions about this, direct it certainly to your liaisons or me. But this network was really created to bring people together and have some crosstalk across departments and divisions. As mentioned, another goal, and especially in this last year, has been to develop partnerships with other Yale School of Medicine affinity groups. So this includes the Dean's Advisory Council on LGBTQ+I issues, the Faculty Advisory Council, the Minority Organization for Retention and Expansion, the Women's Faculty Forum, the Asian Faculty Association at Yale. So really intending, I think we are going to be stronger together if we bring together all of these affinity groups. The individual affinity groups may have, slightly different focus or mission. I think many of the pressing issues, especially right now, affect all of us. I'm just going to give a couple of examples of some of our current swim projects so that you can just get a sense of the types of things that we're doing. But I hope that you can listen to this with this lens of swim really as a place of advocacy and a place that if you have questions or concerns, you can certainly bring them to your liaisons, or you can bring them to swim. So Valentina Greco and I helped co-lead an effort to look at leadership searches. So the goal was to collect and represent experiences of women and non-binary faculty who served on chair-level searches since 2021. We looked at 11 total searches, and that included 131 search committee members. And members were invited to participate in informal small group conversations. 21 faculty volunteered for these, and we interviewed 20. We were trained on doing qualitative interviews. This was actually another really fun way. I still feel relatively new at Yale, but I got to meet some really cool people. We found that there were converging themes around power, culture, and inclusion that affected sort of the success and experiences on the search. Key determining factors included the role of the dean, the role of the chair, the role of the search firm, search committee member composition, inclusion and belonging, the search process itself, and the language of inclusion. This project was conducted with support of Nancy Brown, and we had sort of iterative feedback with her and provided some recommendations. There's an ongoing project looking at sponsorship. I think this is actually really great and has some practical takeaways. So Susan Kashyap and Mohini Ranganathan are really leading this effort. So there are 3 specific recommendations, and one is developing award nominating committees within sections. So cataloging available awards, nominating candidates with the goal of increasing nominations, particularly for members of underrepresented groups. So being incredibly intentional about who we're recommending for awards. A sponsorship party, maybe we can include that in the reception. So an event that's in person or virtual in which participants present prepared sponsorship asks, like, I would like to get nominated for ELAM, like who's going to do that for me? And so, or other awards or speaking opportunities. And then sponsorship focus groups. The goal of the focus group is to collect data on barriers to sponsorship at YSM across a broad representation of faculty and to develop action items. So this is ongoing work. Stay tuned as it makes its way to different sections and departments, but this has been piloted in the departments of psychiatry and immunobiology. Childcare and family care. So Nina Stachenfeld has led this effort. She's leading the Women's Faculty Forum right now and was a past co-chair of SWIM. So SWIM and the Faculty Senate have joined forces and have proposed a provostial committee to examine ways to improve family support. This includes childcare and elder care at the Yale University level. And the provost, they have met with the provost, who suggested that a separate committee be performed kind of outside of that provost's office with the goal of presenting ideas to university leadership. So that work is ongoing. And this is really, again, a collaboration across multiple affinity groups. This is actually a fun project. So the history of women at YSM. So there's a medical student, Naomi Rogers, who's a historian, and Peggy Bia, who are bringing together and trying to really create a legacy work of history of the advances made in equity for women faculty at YSM, really building on that 100th anniversary celebration. So the process will include exploration of archival data, interviews with women active in gender equity since the 1960s, and in recent years, and it's sponsored by the Office of DEI. This is actually going to be a formal medical student project with Elaine Yang. So this is ongoing, and so please stay tuned about this. And then lastly, there's a library project that is hopefully will launch this year, being led by Drs. Anne Monju and Peggy Bia, which will showcase women faculty in the area opposite the classrooms on the lower level of the medical library. There are a bunch of wall spaces that have space for monitors, and we will have rotating content that highlight the work of women faculty, a word cloud with meaningful words and phrases reflecting women's engagement in YSM. And that planning is in progress. So as we move to kind of current times, I just want to acknowledge, I think as Mridu did, that there's a lot of uncertainty and change happening, and certainly in the world and locally around Access 365 and nationally around some of the NIH policy changes. And I think as I reflect on SWIM as an advocacy group and all of us in our roles as physician advocates, it's really tricky to think about advocacy in these times of uncertainty. And so I think look to some of these affinity groups, SWIM certainly being one where we can help nudge at things or be a sounding board. I want to just give some examples. So the March 7th Stand Up for Science gathering, we had a number of SWIM members that participated. So Valentina Greco and Rachel Lampert. This was really led by Megan King. We had a number of people go to Hartford for this event. SWIM sponsored recently a webinar with Representative Rosa DeLauro. This was just a couple of weeks ago on federal funding for medical researchers. She's very engaged. We hope to have more of these, so please stay tuned as you'd like to learn and engage with how we can advocate on a kind of more state-based and federal level. And then I think if one thing I've certainly sort of another hat that I wear is, and certainly since leaving my last institution, and some of you know my story, but I left due to gender discrimination and have really leaned into my role as a physician advocate. I think it not only brings me a lot of joy, but it makes me feel like I'm making a difference and helping to move the needle. And I think that hopefully we can all embrace our roles as physician advocates during this period of uncertainty and change. So anchor advocacy in your purpose and values, advocate for yourself, for your patients, science and learners, for our profession, and for what's right. And I think this is really going to take all of us to make it through some of these complicated times. I want to just share like a little story because I think there's some light in some of this darkness. As I give talks on DEI and kind of promoting diversity in medicine, I heard from a participant in one of the talks that I gave who said that he had his 17-year-old daughter at the time watch one of the talks that I gave. She's an artist and had done this sort of drawing and kind of multimedia art on herself, her mother, and her grandmother, and how they had been silenced through the generations. And I thought that this was just really powerful. So as we think about leaning into our voices for the time that we're going into, I thought that this was just a really important reminder. And then one of my favorite advocates. So I'll leave you with this quote. So fight for the things you care about, but do it in a way that will lead others to join you. And then just a funny sort of anecdote here on the right. So so RBG is like one of my favorite advocates. I have given out the RBG figurines to friends. And then I had a friend give the figurine to somebody else. And then her young son was playing, and RBG was like fighting the dinosaur. So as we all think about kind of the figurative dinosaurs and challenges that we have in our life, you can certainly channel this. So So thank you for allowing me to talk tonight, and hopefully this gives you a sense of what SWIM is doing.